Ladies and gentlemen, the one and only.
Hey everybody, with time for ear, nose, and throat. What do we got here? We got an ear that is retracted, and that is immobile, retracted ear. I got redness, I got bulging, I got pain in my ear. I got a 4-year-old boy who comes tugging my rear, and what do you see there? You see redness and bulging and retraction. You can't see immobility because you need to do insufflation. What's the most accurate test? The most accurate test of otitis media is tympanocentesis. Did I say to do that? I never said to do that. Did I say to do it? I never said to do it. But it is the most accurate. I never said to do it, but it is the most accurate. The most accurate is a tympanocentesis. What are we going to do? We're just going to see immobility. We treat it empirically. Amoxicillin it was. Amoxicillin it is, because we got otitis. Oh, look at that nasty, gooey middle ear. Look at that nasty, gooey middle ear in there. Yes, because this shows purulent material. It's pus in there in the middle ear of that otitis media. There's pneumococcus, haemophilus, mozzarella, boogeralis. Moraxella catarrhalis. Moraxella catarrhalis, gram-negative, diplococcus. We have pneumococcus, gram-positive diplococcus, and we have Haemophilus influenza, a misnomer. It doesn't cause influenza, it was a mistake, but that's a gram-negative coccobacillus, somewhere between a rod and a coccus. It's either a short rod or a long coccus, depending on your point of view. So that's what causes that bulging red tympanic membrane and otitis media. Pneumococcus number 1. Most accurate test is to aspirate it. Now remember, there's a difference between saying what would you do versus what is the most accurate. What would you do? We're not going to do that, but it is the most accurate. Now the step 1 question is, the culture shows what? The culture can show pneumococcus. The tympanic membrane is aspirated if it recurs and recurs and recurs and recurs, fails treatment, and then you take a sample so you can get the organism. And the usual empiric therapy is amoxicillin, a decongestant. Now, the most sensitive physical finding of all is immobility. You put air and a tympanic membrane should move, because that's how you sense sound. The tympanic membrane moves because that's how you sense sound. But if you have purulent material, it won't move in there. Amoxicillin is the best initial therapy because well, to be honest, the reason it's the best initial therapy is you could give nothing and would get better 70% of the time. The whole management of otitis media, as well as pharyngitis, has changed in the last 30 years from a massive overtreatment to realizing most of them are viruses which get better on their own. Now, what is the organism? This is the otitis. And those 2 big things over there, that's a pneumococcus. That's a pneumococcus. These are pneumococcus when you see them on a smear. These are pneumococci, these lancet-shaped little coffee bean-shaped things. Ooh, look at this. This is also those lancet-shaped coffee bean type things. And let's see, the pneumococcus is a non-motile. Catalase is able to neutralize hydrogen peroxide. Let's get with the microtime. The microtime. The microtime. Catalase negative and oxidase negative. That's what pneumococcus is. Okay? So alpha hemolytic strep is strep viridans. Ooh, looks rather green. It's not easy being green. Alpha hemolysis I've seen. Now, beta hemolysis, complete hemolysis. Okay? And so, let's see, on to the next one. You see, let's take a look at this. The opticin sensitivity is going to show that pneumococcus is opticin sensitive and viridans group strep is opticin resistant. Now, there's no capsule on top of that viridans group strep. There's no capsule. So there's quite a bit of difference, isn't there? You see, Viridin streptococci has no capsule, bile solubility is negative, there's no swelling, and escalin is negative. Okay, pneumococcus is encapsulated. Pneumococcus bile solubility is positive, and there's swelling. Is swelling because there's a capsule that can swell. So if nothing else, what do we get out of this section? We get to know the difference between alpha hemolysis is green, that's strep pneumonia, and viridins strep pneumonia, and viridins is alpha hemolysis. Beta hemolytic is strep pyogenes, group A beta hemolytic strep. That's the strep throat strep, that's the necrotizing fasciitis strep, that's the strep throat strep, that's the necrotizing fasciitis strep, that's the post-strep glomerulonephritis strep, that is the rheumatic fever strep. Strep agalactiae, also beta hemolytic. Strep agalactiae, that is the neonatal meningitis. Neonatal meningitis. And gamma hemolysis is no hemolysis enterococcus. We're not going to ask you to know so much of the specifics between the difference between faecium and fecalis, because from our point of view, faecium and fecalis are largely the same bug. Is this a gram negative or a gram positive? This is a gram. Look at the world here. Isn't it amazing? Look at the world. This is a gram negative. This is the gram negative coccobacillus known as Haemophilus. This is the number 2 most common cause of bronchitis and otitis. Bronchitis and otitis. It's a fastidious gram-negative coccobacillus. It needs factor 10, the hemin factor or factor 10, the microbiology of these organisms. On to the next subject. What is this? And when is this the diagnosis? When do you see this there? What is it? Battle sign. It's a hematoma. It's a hematoma over the mastoid process. What does it indicate? Battle sign. What does it indicate? It indicates battle. It indicates a basal skull fracture. The base of the skull is fractured. Now, base of the skull fracture. Now, almost never is skull x-ray the most accurate test. Almost never is a skull x-ray the most accurate test for anything. So skull x-rays is a very unusual thing to ever do, because anything that you need to do is look for blood, you need a CT scan. So a CT scan is the way we're going to be able to tell, is there anything meaningful? Meaning that you can have a skull fracture, but no blood. You can have skull x-rays with no fracture, but still have blood. And that's why the CT scan is more important than any x-ray. Because we want to see battle sign, basilar skull fracture. Battle sign, blood in the tympanic membrane, skull fracture. Battle sign, basilar skull fracture, behind the ear, over the mastoid process. Damn, it's making me sick just to think about it. But you know what's worse? If you don't catch it, if you miss it, you're going to kill somebody. And you want to be good doctors. You want to read that letter that you wrote when you went to medical school. You want to read that letter that said, I want to go to medical school because I want to be a great doctor. I want to go to medical school because I want to take care of people and I want to do the right thing. I want to help a suffering humanity in their hour of need. And you're going to be able to do that. You're going to be able to do that. You're going to see patients every day, just like the fish do. Now, when you have a basal skull fracture, the blood oozes. It oozes. It oozes towards the ear. It oozes towards the ear. Base of the skull fracture goes through. Looking at the bottom. See, these are the upper incisors. Upper incisors. Just looking at the bottom of my head. Looking at the bottom of my head. Looking down from the top. That's why this is the right ear and this is the right ear. Right ear, right ear. And the blood dissects through. Pause. Absorb. Now, ooh, that's bulging. Bulging in red. That looks terrible. Oh, but that's not the main thing. You see that little baby, you see that little baby thing there? Oh, that's it. The most accurate test. What is this? Therapy, you see our theme. Wow, this is otoscopy. This is looking in your ear, isn't it? That's looking in your ear. Now, personally, I would have wedged and had this hand sandwiched on the head to stabilize it against the head. That's what I would personally do. But this thing that you saw in the ear, that thing you saw in the ear, that's called bullous myringitis. That's a bulla that's on the tympanic membrane. Something on the tympanic membrane is called mirring something. If it's on the tympanic membrane, it's called mirring something. Myringitis is a bulla on the tympanic membrane. And it's described when you see somebody as mycoplasma pneumonia. Now, most people don't remember that mycoplasma pneumonia is associated with bullous myringitis, but it is. And bullous myringitis can also be with cold agglutinins. What did we say what the difference between cryoglobulins and cold agglutinins? Cryoglobulins is hepatitis C, kidney, skin, joint. Hepatitis C, cryo, kidney, skin, joint. Cold agglutinins, hemolysis. Both are IgMs. Both are IgMs. The most accurate test here can be cold agglutinins, looking for Epstein-Barr, antibodies against red cell membranes, resulting in that. That is a bullous myringitis. That thing. That's a bulla on my tympanic membrane. That's a bulla on my tympanic membrane. That's a bulla. See, I'm standing in my bulla. My head's in a bulla. Help me, help me, help me. My head's in a bulla. Yes, bullous myringitis. Ah! Next slide. That's normal, believe it or not. That's normal. One shit-eating grin. Whoa! That's terrible. That's not normal. That's normal. That's not normal. That's normal. Ooh, keep your eyes closed. This is why people close their eyes when they kiss, so they don't see this sort of stuff. So this is, what is abnormal in there? This is gingival hyperplasia. And gingival hyperplasia happens from anti-epileptic drugs. Gingival hyperplasia happens from anti-epileptic drugs, and gingival hyperplasia can happen from people who are going to have things like phenytoin. Gingival hyperplasia can happen from phenytoin, but also cyclosport, calcium. Did you know that calcium channel blockers? Very few people know this, that calcium channel blockers cause gingival hyperplasia. And if you knew that calcium blockers cause gingival hyperplasia, you are way ahead of the game. So you stop the drug that's causing it, and there's nothing else to do about it. What do? Nothing. Brush your teeth, debride it, get out of the way. Ah! It's like an alien movie. Next slide. What's that gooey, cheesy stuff in the back? What is that cheesiness? Oh my God, this is a non-kosher pharyngitis. Why? Because I got cheese with your meat. Non-kosher throat. Oh, it is. It's fungal pharyngitis. The most accurate test in infectious disease. In infectious disease, the radiologic test is never the most accurate test. The radiologic test is never the most accurate test. So it has to be a culture. So KOH, potassium hydroxide. Step 1 question, the big step 1 question. And don't forget that there's going to be diagnostic test flashcards too. Look at that one too. Same idea. The diagnostic test flashcards are for the diagnostic tests, the pathology, the clinical pathology of all tests. And believe it or not, there's only 200 of them. Same as the physical findings. So the test, potassium hydroxide, melts away the epithelial cells, melts away the epithelial cells and only leaves the fungus, because fungus is not destroyed, because fungus has chitin. And chitin is in the surface of fungi, and it's like a lobster shell. hard and doesn't melt away. Epithelial cells, relatively speaking, are soft and they melt away. But chitin, which is in the fungus, does not. And that's why potassium hydroxide is the first test and fungal culture is the most accurate test. We have the throat cheese zone. What do you do for the cheese in your throat? Aha! If it's just in the throat, we can use nystatin, clotrimazole, or fluconazole. Nystatin, clotrimazole, or fluconazole. If it's just in the throat. Oral candidiasis or thrush happens in people who are HIV positive, diabetics, steroid users. You know this is the biggest adverse effect of inhaled steroids? Yes, it's the biggest adverse effect of inhaled steroids. It also shows you why are inhaled steroids not benign. Because inhaled steroids can cause this and give you immunocompromise there in the back of the throat. HIV, usually less than 200 T cells. Now, we generally don't have to do potassium hydroxide or fungal culture. However, it is the best initial test and the most accurate test. What would you do? I'd give antifungal. What's the best initial test? KOH. What would you do? Give antifungal. What's the most accurate test? Fungal culture. Seems paradoxical, doesn't it? It's not. You're going to get all the questions you need right from here. You're going to understand everything in one unique, cataclysmic, overwhelming envelopment of all human knowledge bursting into your brain now. So, unlike hairy leukoplakia, it does not scrape off. It does scrape off, because hairy leukoplakia does not scrape off. That's the point. Fungus does scrape off, and hairy leukoplakia does not. That's the difference. That's how you tell it apart. Candidiasis scrapes off, unlike hairy leukoplakia, which does not scrape off. Candidiasis does. Clotrimazole, econazole, turconazole, fluconazole is the therapy. They inhibit ergosterol in the fungal cell wall. Speaking of fungus, here it is. These are the little yeasty beasties. Here's the little yeasty beasties with the budding yeast. Aren't they beautiful? They're so beautiful. They're budding. I want to eat one. Yeah. Budding yeast. Looks tasty, huh? And you see those little buds? They become these things that sometimes are called germ tubes and later become pseudohyphae. Why is it a pseudohyphae, not a hyphus? Because hyphae, have real septa. They have real borders there, like aspergillus or mucormycosis. But this is a beautiful picture of budding yeast and hyphae as they're forming. Budding yeast, bud. Come to think of it, I'll have a bud. And this is the colonies. What is the basic science question? What's the agar this is growing on? This is yeast. What's the agar? You notice that there's no blood in it? You notice there's no blood in it? There's no blood in it, there's no blood in it, there's no blood in it, and it's very sweet. That's sabarodes or sabaril. Because the D is silent if you want to pronounce it correctly, so that the French don't have flatus in your general direction. Okay, but sabarodes, agar, is very sugar dependent, and this is yeast growing up on the sugar in the fungal culture. This is a scanning electron micrograph. That's why they look so colossally huge. So let's go back to these. These are light microscopy. You see, these are light microscopy. That's light microscopy of budding yeast blown up very big. Light microscopy. This is scanning electron microscopy of a budding yeast. Whew. Now, fungus is commensal flora. And it is found commensal, meaning it just lives there. meaning that it's not pathologic. When the fungus is in your mouth, it's not considered pathologic. When it's in your GI tract, it's not considered pathologic. When it's in your vagina, it's not considered pathologic because it is natural to have a little yeast. You know, we've read like Hemingway, the sun also rises. Well, you could say the vagina also rises. And there is yeast naturally also rising, yeast, from mouth, GI, and vagina. So if you told me that you saw fungus growing in a certain specimen, you'd have to tell me what the specimen is. If it's GI, mouth, or vagina, I would say, who cares? If it's blood, I would say, I care a lot, because it's not commensal in the blood. Okay? Those blastoconidia are budding off the sides of the hyphae. These blastoconidia off the sides. And the pseudohyphae, because they have no septa. That's a very step one thing. Asking about septa is not step 2 or 3. People who don't care that much about septa in step 2 or 3, all we want to know is the treatment of this stuff. This is a colorized scanning electron micrograph of a candida that is yeasting, budding off. Catalase positive means it degrades hydrogen peroxide. And it degrades hydrogen peroxide, meaning that it can fight off the countermeasures, because hydrogen peroxide is a way of stopping bacterial infection, stopping fungal infection. But catalase positive means that the hydrogen peroxide, catalase positive means that the hydrogen peroxide that normally would be released to kill off bacteria and fungus, that hydrogen peroxide is itself degraded and prevents microbicidal activity. Azole antifungals block the conversion of lanosterol to ergosterol. You see the key word there? Sterol, sterol, sterol? That's because it derives from cholesterol, because the cell's surface, the cell covering of fungus has cholesterol, and it blocks the formation of ergosterol. Our next section, in our next case, scrape, 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 nothing comes off. An HIV positive patient is found with white lesions on the side of the mouth and tongue that do not scrape off. What is shown? It is hairy leukoplakia. What do you do about it? Not anything specific to hairy leukoplakia. What is it? It is oral hairy leukoplakia. Leuko meaning white plaques. White plaques. Well, it is white plaques. It doesn't scrape off like yeast. Yeast scrapes and hairy leukoplakia does not. The reason it's found in HIV is because HIV is T-cell immune deficiency. So it'll be found when you have a T-cell immune deficiency, and it's an asymptomatic on the side of the tongue, and you just have it. It's fuzzy. It's like Epstein-Barr in a way. Oh, and it's associated with Epstein-Barr, but it doesn't cause lymphoma. Now, leukoplakia in smokers happens, and in smokers it can be considered a pre-malignant lesion for squamous cell cancer in the mouth. But oral hairy leukoplakia in most people is not a pre-malignant disorder. Okay? It's distinguished from candidiasis because it doesn't scrape off, and it doesn't, we're not clear, well, this is a slight fuzziness. Does it get better with acyclovir? Could it hurt? Oral hairy leukoplakia doesn't scrape off. It's associated with Epstein-Barr virus. Is there a treatment? Yeah, not really. And this is a photo micrograph of oral hairy leukoplakia. And you'll notice the stratified squamous epithelium on the surface, the stratified squamous epithelium, the superficial layer of the tongue, cornified. Okay, and this is actually what a tongue biopsy would look like of oral hairy leukoplakia. It's a strawberry tongue. What is it? Yeah, what is oral hairy what is a strawberry tongue? Most accurate, it happens with streptococcal infections. Strawberry tongue happens with infections, happen with Kawasaki's disease, strawberry tongue, the papilla. The papilla. When you see strawberry tongue in the history, the papilla are exaggeratedly large. It can happen from group A strep, strep pyogenes, that's the strep throat strep, that's the rheumatic fever strep, that's the post-strep glomerulonephritis strep. Okay, with group A beta hemolytic strep can be Kawasaki's, which causes aneurysms. Okay, Kawasaki's. Now B12 deficiency, I don't understand at all why it's there. It does cause tongue findings, B12 deficiency, and nobody knows why. But streptococcal infections have toxins. It's hard for people to understand that, but they do. Streptococcal infections have toxins. So since streptococcal infections have toxins, they can cause these things like strawberry tongue. Now, the rapid strep test is looking for the antigen on the side of streptococcus. The antigen on the side of streptococcus in the streptococcal infection on the rapid strep test. But what you notice is we never gram stain a tongue. We never gram stain a vagina. We never gram stain a throat, because all throats and vaginas and stool have streptococcus. But you can't tell it's group A streptococcus, strep pyogenes, until you either do a rapid strep test or a culture. The single most accurate test is a culture. And a positive rapid strep test, looking at latex agglutination, a positive rapid strep test is the same as a positive culture. This is streptococcal toxin, this is streptococcal toxin. These are the exaggerated papillae of the toxin of the streptococcus. Next card, what's the Weber and Rene? The Weber and Rene tests are tests of hearing. They are. The Weber is done with the tuning fork in the center. You normal person should hear it equally in both ears. Normal person should hear it equally in both ears. But a person who has a conductive hearing loss, it'll start to lateralize to one side. Weber sees whether you have a conductive or sensory neural hearing loss. And Rene test does a similar thing. And some people who are medical students spend the entirety of their second year of medical school just to understand the Weber and Rene. Now, what is an abnormal Rene test? A Rene test is that you hold the tuning fork to their mastoid process, and then you take it off and put it in their ear, and a normal person should be able to hear it. But if you hear it here, but you don't hear it here, it means a conductive hearing loss. Here we go.
Can you hear that there? Hear it over here? Harder to hear over there? Okay. All right. Can you feel it in the middle or to one side? Feel it over there? Okay. All right. Can you feel it back here? Okay. Tell me when it stops.
It stopped.
Can you still hear it? Okay.
It's normal to hear a tuning fork with the air more than the bone. Air conduction should be greater than bone conduction. That's normal.
It stopped.
Can you hear it?
He doesn't hear it. That's because it's a conductive hearing loss. He doesn't hear it. See, if it was a sensory neural hearing loss, he wouldn't hear the tuning fork whether it was in the air or attached. A sensory neural hearing loss would not be heard in either one. A Weber, if it's a sensory neural hearing loss, you'll only hear it in the normal ear, if it's a sensory neural. The Weber's test is placing the tuning fork in the top of the head. and the patient is asked which ear is louder. A normal person hears it equally in the middle. A normal person. A normal person should hear it equally in the middle. Okay? The Rene test, the RIN, the tuning fork is placed on the bone. And then you take it off and say, can you still hear me? A normal person should still hear you because air conduction should still be greater than bone conduction. When the sound is no longer heard when it's touching, the fork is placed closer to the ear but not touching. This is going from bone conduction to air conduction. Normally, the bone conduction should be able to, you should be able to have that bone conduction continuing to persist. But if it's a sensory neural hearing loss, you won't hear it under either circumstance. Now, a normal person is still able to hear the sound after it's removed from the bone because air conduction should be greater than the bone conduction. Air conduction should be greater than the bone conduction. Can you still hear it? Oh, I can still hear it. Touching. Air conduction. Air conduction should be greater. An abnormal Weber test is heard louder in an abnormal ear for conductive loss. Now, this is very hard to understand, by the way. This is the main reason that people, by the way, I understand very well that most people just completely lose consciousness on these hearing tests. Air conduction should be greater. I detach. That's normal. If you have a sensory neural hearing loss, you won't hear either one. And if you have a conductive hearing loss, the normal air conduction being greater than bone conduction will be missing. The Weber should be heard equally in both ears. If you have a sensory neural deficit, you won't hear anything in the abnormal ear whatsoever if it's sensory neural. But if it's conductive, a conductive hearing loss will be heard better in the abnormal ear. Conductive hearing loss lateralizes to the impaired ear. Sensory neural losses to the good ear, because a sensory neural loss means you're not going to hear anything at any time. So the only way you'll hear about it is in the good ear. The only way you'll hear about it is in the good ear. A Rene test would be the bone conduction greater than air conduction, meaning I don't hear anything. Abnormal is when bone conduction is greater than air conduction. Normally, air conduction is greater than bone. Weber and Rene are difficult. Go over it again. The fish loves you. See you.